Thank you, Laura, for that just outstanding testimony. I think it is just very moving for me to hear real-life experiences of the topic, the very difficult topic that I'm going to share with you this morning. And there's a couple of things that I want to begin with, just set the stage. And really, I'm a physician scientist, I'm an academician, and I do want to share with you many aspects of medicine and biology, but I recognize we've got a very diverse audience, and I'm not intending to make you physicians or scientists. I know that many of you are dealing with this issue from a number of different vantage points, whether you're a minister, whether you're personally affected by this, whether you have a family member. And so what I intend to share with you is a way to enter into the conversation. This is something that is so prevalent in our society right now, it's very hard to avoid this. And many times we're faced with challenges to our beliefs, our understandings of who we are as sexed beings, as human beings. And I want to give you at least enough information so that you can enter into that dialogue and be able to maybe challenge some of the ideology that is so prevalent in our society. It's very interesting because I'm going to talk a lot about science and medicine and best medical practice, academic topics, but I'm required by my university to make this disclaimer that I'm disavowing my affiliation with my university because of the politics involved here. Now, just to set the stage, the topic we're going to be talking about is that of identity. This is who we understand ourselves to be within ourselves and in relation to other people. And this is a part of us that is so central to our being that it's very heavily guarded. And when anyone challenges one's identity, it's bound to elicit a very deep and often visceral response. So if you're involved in conversations and you experience this, either within yourself or with the person that you're speaking with, it's probably the basis for that. But I want to move beyond the emotive, and not to dismiss it. It's a reality, and we need to acknowledge it, but to think objectively and to be able to arrive at an understanding of truth and be able to speak that truth with love. Okay, and that's really our goal here. I love this quote from a brilliant philosopher and theologian, Karl Wojtyła. You probably know him better for his treatise on the theology of the body, a beautiful teaching of understanding who we are as created in the image and likeness of God, but also recognizing our brokenness and what we've experienced through the fall and how we deal with that. But the important part for our talk today is maybe one of his other writings on faith and reason. And he speaks very eloquently about this. He says that faith and reason are like two wings on which the human spirit rises to the contemplation of truth. And God has placed in the human heart a desire to know the truth, and in a word, to know himself. And so that by knowing and loving God, men and women may also come to the fullness of truth about themselves. Now, what this says is that faith and reason are not in contradiction. We're talking truth, speaking truth. Areas of theology and what we can learn from faith are incredibly important, and there's a dimension of that we could mine for quite a long time. But when we talk about areas of science, they're not in contradiction. And so that we need to recognize that and really bolster ourselves to understand what can we learn from the sciences, what can we learn from the fields of biology that helps to complement what we know from our faith. So let me begin with just some very simple basics. And maybe a couple decades ago, we wouldn't need to put these terms up here to really define what we mean by sex and gender. But many times words have become weaponized, and many people have understandings and meanings that they apply to these terms that may be confusing in the conversation. When I talk about sex, I talk about the biological reality of people being created as male and female for the purpose of reproduction. And that is a term that we've known in science forever. And it doesn't apply just to human beings, it applies across the animal kingdom, that there are defined roles for males and females in participating in that reproductive process. And we can go into great detail, and it's very objective to know the role of the male in supplying the sperm to the female who supplies the egg that occurs within the female body for that process of conception and the rearing of that, the development of that child. That's a very, very clear definition. But there are many people that want to use that term and that understanding and make claims that one's perception of oneself, gender, our way that we socially interact with others as masculine or feminine, that is the determination of actually sex. There are many people that will say gender identity is sex, that it's all in the mind, that we can create who we are as human beings. Now, it's very important to recognize that as we're talking about these terms, it can be helpful to segregate out sex and gender. But you can't completely dissociate that, because when we talk about what we mean by gender, how we interact in society as masculine and feminine, has everything to do with that reproductive process. About two different members of the human species come together and form a relationship. And not only in the conception of that child, but the raising of the children that come from that reproductive encounter. So that we need to recognize that this goes hand in hand. Now, at the heart of our conversation is this concept of gender identity, and this is where one perceives oneself as being male or female. And that is at the heart of the pain and the suffering that I'm going to be talking about this morning. The last term on the list is that of sexual orientation, and there is a relationship. There's a very clear relationship, and many times many people that adopt a sex discordant gender identity are struggling with issues of same-sex attraction, and that even as they resolve gender identity issues, they're often left with some of those wounds and struggle with that. But as we think about this, let's just put this in perspective, because the way that people try, many of the ideologists will try to distort that beauty, the beauty of man and woman created in God's image and likeness, and all of the dimensions that go with that, is to say, sex is not binary. There's not just male and female. There's a whole continuum of a human experience. And what they often do is they draw to the area that I engage in my medical practice, those individuals, the rare individuals that are born with disorders of sexual development, where there's genital ambiguity, where probably the only time in one's experience where the standard question, is it a boy or a girl? The answer is, I don't know. But for 99.98% of the time, one can correctly recognize, not assign, but recognize the sex of an individual just by merely looking at the appearance of the external genitalia. And what we have to keep in mind is in relation to what we mean by sex. And if we understand sex in relation to reproduction, there are two, and only two, gonads that participate in that process. There is not an infinite number of gonads that allow for new life to be created. And generally, people that experience disorders of sexual development have impaired fertility, and many of them are infertile for their entire lives. So keeping that in mind. Now, the other important part, and I think it was just mentioned earlier, and apparently you had a talk yesterday or earlier in this conference, recognizing that sex is not limited to the gonads or the reproductive organs. It's a part of our entire being in every cell of the human body. And actually that sex determination occurs at the moment of conception, and the genetic information that directs sexual development is very, very important in non-sexual organs and other cells of the body. And this will be important when we talk about medical management of gender dysphoria, recognizing that the giving of medications like testosterone to a female and estrogen to a male has very, very serious consequences. It's not only that the genetic information is present in every cell of the body, but there's genetic programming in an area that we call epigenetics. The sequences of the genes don't change, but there are differences that allow responses to signals to vary. And the best example I like of this is that in an area of medicine where you can inherit a mutation mutation, either from your mother or your father, and the exact same genetic mutation leads to two entirely different diseases. The example I like to use is a chromosome 15 mutation leading to Angelman's or Prader-Willi syndrome, but you don't need to know the details of that. Just recognize that the epigenetics is important, and it's a programming of our body, and that there's differential expression of these genes throughout the body that are different between males and females. And if you look in detail about what those differences are, strikingly, they have much to do with the roles that males and females are called to in that whole role of human sexuality. And it's amazing. But now this topic is this condition where somebody has a sex discordant gender identity, so that if you're male and you perceive yourselves to be female or a woman, this is a reality that we know about. Until very recently, it was incredibly rare. And the way the medical profession has understood this has evolved over time, not based upon new information about scientific understanding, but really following within the political and social discussion that's going on, ideological assumptions. And this is best probably illustrated in how we define the condition itself. The psychiatry manual that defines various conditions used to understand this condition as gender identity disorder. They used to recognize it as something is not right. But because of all of the cultural changes and the ideology, they redefined this to focus on this discomfort that one experiences between their sex and how they perceive themselves. This term used as gender dysphoria. In fact, there's a movement now to get away from gender dysphoria, that even that seems to be stigmatizing, and just talk about gender incongruence. The reason why this is a medical diagnosis is to allow the medical profession to engage in procedures to help one align their body to their perceived gender identity. It's the only reason it's there, and many would want to get it out of there altogether. But this is what we're dealing with. And why am I, as a physician and physician scientist, involved in this area? Well, we all seek to avoid suffering, and we try to heal the individual when things go awry. And we need to recognize that people that have this experience, that have gender dysphoria, are truly suffering in a variety of ways. It's very well established in the literature and not controversial that there's an alarmingly high rate of depression, suicide, anxiety, eating disorders, people engaging in behavior that lead to sexually transmitted diseases, that they've been exposed to sexual and physical abuse. This is incontroversial, okay? And we can recognize and with true compassion, understand that suffering, because what people are doing is they're screaming out for help. They're trying to be able to be healed. And as we know, and we've heard from the testimonies here, we know who the divine healer is, right? But the medical profession, with that in mind, again, any good physician thinks holistically. We don't just segregate it into just biological facts. We need to understand the psychological dimensions, and we do need to understand the spiritual dimensions of who we are as human beings as well. The question we have to ask is, what is the medical profession doing, and is it truly helpful? And it's becoming a greater a problem. And a decade ago, when I first got involved in this area, it was very rare that I actually encountered somebody that was directly affected by this. And now most people in the room here have experienced or heard about or know somebody, a relative, a friend, or even some of the people in the room here that are experiencing some of these challenges. And it's really grown exponentially. The data I have on the slide here is from one center in the United Kingdom, the Tavistock Center, where all the patients in that country have to go to get this affirmative care approach. And we can just see how it's been skyrocketing over the years. And there are many interesting trying to understand what is going on here, to look at the demographics, the epidemiology. There's a changing dynamic right now. It used to predominantly affect biological males identifying as female that usually presented very early in life and then sought to go through these interventions later. And the largest segment of the population that is now coming forward with sex discord and gender identity are adolescent females without any prior gender dysphoria until they reach their teenage years. And oftentimes actually within social networks. And the claims are made, well, they always existed and now there's gender centers growing throughout the country and now they have a place to go. And there's really been no change. It doesn't really make any sense if you think about this from an objective perspective. And maybe an alternative hypothesis is that maybe what's going on in the cultural conversation, the social networking, this concept of rapid onset gender dysphoria is playing a major role. And I won't go into detail about that, but it is something, as we try to ask the question, what is going on here? What is the cause? What is the etiology, as we say in medicine, of this sex discordant gender identity? There's a lot you might hear about, saying that one is born that way. And there's an extensive effort, just like there has been in same-sex attraction, to identify, the gene that's responsible for this. They've not found it. They likely will never find it. But there is evidence that there are genetic influences. So we can't dismiss it outright that some people are more predisposed with the same types of factors that may contribute to this emerging. And it doesn't mean that there's a miswiring in the brain necessarily. It may be that an individual has a genetic predisposition, to handle stress differently or has different coping mechanisms. And one of the most interesting findings is this link to autism, that not everybody that has gender dysphoria has autism, but there's an amazing increased incidence in those that do. So that tells us something that might be going on. There's a lot of theories about that, just a way about how autistic individuals or people that are on that spectrum think very concretely, and that when they have this difficulty, they often then assign it to gender dysphoria. The environmental contributors, however, in the area of psychosocial or psychopathology, there's this, I mentioned the association between depression, anxiety, and many other psychiatric illnesses. Many times they will predate an individual having that experience. And many people say that the depression is because they have gender dysphoria, and that if you take care of the gender dysphoria, then that depression will go away. And I'll show you some data that actually challenges that. But probably the biggest area that has been not fully explored and provides many, many clues, if you listen to the stories of the individuals that have had this experience, about the environmental factors, and we heard about it, this morning as well from Laura's testimony, about the lies that one accepts, and the difficult ways to respond to stresses like physical or sexual abuse. A very common theme that we see in individuals, for example, females that have been abused, that will adopt a male gender identity in an attempt to heal that wound. There's much that needs to be studied in this area. The best we can probably say at this point in time is that it's multifactorial, that in any one individual there are a number of different factors coming together and that differ in both nature and degree that are leading to this experience. And I think that, but we really don't know. So we're operating out of a stance of not full understanding, and we can ask many hypotheses, and many of them it can be related maybe to spiritual experiences as well. So I think that we definitely need to know. But I want to actually just address one area, because we're often told these people are born in the wrong body, and they often try to say that the brain is geared toward this. Just let me say just a little bit about that. It is true that if you look at the structural differences between male and female, just like I mentioned before in the epigenetics in every cell of the body, that there are clear differences between males and females, and many of the differences have a lot to do with the different behaviors that males and females tend to have naturally, if not without any intent, just in general observations. Yet that does not mean that that is determinative of one's gender identity. There's, we know that there are females have special graces and gifts that they have and things that they do much more naturally than males. It doesn't mean that males can't do that, but it means that there's an overlap between what we see structurally. And we also know that differences in the brain are often due to environmental experiences. This is a concept known as plasticity, meaning that the brain structure then is also influenced by the environment. It's not necessarily innate. And just to illustrate this difference in as far as overlap, in my area of pediatrics, we focus on growth issues frequently. We know that on average, males are 5 inches taller than females. That's very well established. But I challenge any of you to determine the sex of an individual by measuring their height. You can't do it, right? So I think we can dismiss that outright as far as being the determinative factor, but we need to be aware of that. Now, I want to transition now into talking about really the attempt to alleviate that suffering and what is being put forward as far as what is the compassionate response and how, at least as the medical profession, is being engaged in this conversation of what can be done. And it's often put forward that this affirmative approach is the only approach that one can use, and I'll show you data that allows you to challenge that. But I want to begin with this concept of the reparative approach. Each of the 3 different approaches have different underlying premises and underlying goals. And that really underlies, how we think about this. The reparative approach has as an intended consequence to assist somebody in realigning their gender identity with their biological sex. And I would venture to say that most of you in this room here would probably say that would be a pretty good outcome, okay? The premise is that the problem resides in the psychological realm, that the body is perfectly normally formed, and that the approach to this is to address some of, from a psychological standpoint, what are those underlying difficulties that one experienced, and be able to provide healing to that experience of if they've had prior traumas, difficult relationships with their parents or with other peers. And that is really an area that is underexplored. And the reason it's underexplored is that many of the ideologists have said this is something that we know doesn't work, it's harmful. They draw attention to using the term conversion therapy, drawing upon techniques that were used decades ago in same-sex attraction that anybody would say is unethical, and not allowing for even consideration of this as an approach. And again, this is one of the most violent reactions that I get when I have conversations, to present it in this manner, that the medical establishment has proven that this doesn't work. Well, it actually means that they have not been willing to look at it. There's many psychological approaches that have yet to be explored that are very effective in helping one deal with these difficulties. And I think there's much from the research stance that we can appreciate. The second approach is this expectant, or I say watch and wait approach. So this is based upon an understanding that we don't really know what's going on. We know that in when we look at the experience for children that have gender dysphoria, the vast majority of individuals as they go on with life, if you do nothing at all, will have a spontaneous realignment of their gender identity with their sex. And it may be through experiences like we heard from Laura, where they have an awareness of God's, love and come, to this experience. It may be for other factors as well. And if you think about this, that 85% are going to have this experience if you don't do anything at all, that's not a bad outcome. Because if we think about the affirmative approach, there's going to be many consequences that I'll speak about, that these individuals that have that experience are not going to be medicalized for their entire life and have all of the risks that are associated with these medical interventions. And so that this would be, and there's lots of data. I can give you lots of studies for this. And I think it generally applies more to children, but we're finding that this experience can also be applied to older adolescents and even adults. And again, it's not, the premise is that we don't know who those 15% are. They're going to have persistence of that experience. And again, whether there's methods that we can have that we're not utilizing that may help those individuals as well. But at least in the area of medicine, we look at what we call non-inferiority, that if we're proposing a new intervention, it has to be at least as good as the prevailing intervention. So this is different than the reparative approach, but it is a way that we can wait and help individuals. And it does not mean that while we're watching and waiting that we're doing nothing. I want to make that very clear, that one can engage in all of the other difficulties, so provide psychological counseling and treatment for underlying depression or eating disorders and many of those other morbidities. So this is something that the approach. Now, what we're often told is this last approach is the definitive means, and this is the only method that we know it works, and this has been solved, and everybody needs to affirm somebody that has sex discordant gender identity and encourage them to go forward in this. Not necessarily with all the medical interventions, but we need to recognize and celebrate this. And it's really based upon a premise that this is a part of normal human variation, and that the goal is specifically to allow one to more conform to their gender identity. The way it's engaged, and many of you are already aware of this, blocking normally timed puberty in adolescence, being able to give cross-sex hormones, and then the surgeries that like bilateral mastectomy in females, and then the genital reconstruction surgeries known as bottom surgeries. It's very challenging for somebody that doesn't understand the conversation that's going on right now to challenge that affirmative approach. It's exceedingly difficult. When somebody goes to a provider and they tell you this, if you do not engage in the affirmative approach, you or whoever's affected will commit suicide, and that this will save you, there's not a lot of basis, for you to challenge that if you don't know what the conversation, what the data shows. And in fact, many of the medical associations have adopted this, actually very small segments of medical societies, very focused, ideologically based groups. Probably the most vocal is the World Professional Association for Transgender Health, or WPATH, who makes a claim about having standards of care, which is actually a misnomer. They don't really have a standards of care. And even my own professional association, the Endocrine Society, has put forward this affirmative approach. What they don't tell you is that the evidence, the scientific evidence, is of the lowest quality for these recommendations, meaning that we rank the evidence in making for these practice guidelines, and nearly every single one of the recommendations is based upon low or very low quality evidence. And by definition, that means that the advice is likely to change as new information becomes available. So what is the problem with that approach? Well, the studies themselves are done very poorly, very small sample sizes, not proper controls, sometimes even without controls. There are many biases in patient recruitment. They're often done as observational, cross-sectional studies, which really never can give you an answer as to cause and effect. It only tells you an association. And as we'll talk about, as far as people that have had this experience of desistance, a very alarmingly large number of people in these studies, that when they follow them more long-term, that are lost to follow-up. We don't know whether they've committed suicide or whether they've gone through desistance and then run away as far as they can from the providers that mutilated their body. And so there are many questions that are out there based upon the quality of evidence that's present. And there's not only that, there's a a desire not to do the studies that need to be done, as we do in other areas of medicine. There's claims to say the randomized controlled trial cannot be done in this population because you're going to harm these individuals. So based on a very false understanding of how clinical trials are done and a very strong bias against anything other than the affirmation approach. So you just need to recognize that. Now, as I go, probably most of you that are going to encounter this element of the affirmation approach, that of social affirmation, even if you're not personally involved in that conversation. This is, the allowing an individual to adopt preferred pronouns, dress, bathroom access, athletic competition corresponding to their gender identity rather than their biological sex. If one looks at the scientific evidence, for that, the claim is made that if you socially affirm somebody, it's going to alleviate this dysphoria that they have. And I would say that there is short-term data that actually bears that out. In the short term, that does provide immediate relief. I like to liken it, for example, when we're thinking about kids going through puberty that have this experience. I think it's a good example. That a child's very anxious about taking a math test next week, and if you tell them they don't have to take it, you're going to immediately alleviate the anxiety. But have you really helped that child? There are developmental issues that need to be overcome, and even in adults, there are many challenges that need to be worked through. And if we think about the claims that are being made, there's never been a controlled trial, a randomized controlled trial that looks about outcomes of these individuals that are socially affirmed or not. And there's many concerns right now that the social affirmation component of this is driving people more in that direction. And there's actually good data out there when we get on beyond the social affirmation to the early stages of intervention, even pubertal blockade, that once you enter into this path, it gets progressively more difficult to back out. And that people that would have had this desistance experience if they were merely, left in a neutral environment are now pushed down this pathway to intervene with later stages, which includes the cross-sex hormones. And these are not benign interventions, okay? We're talking about giving estrogen to a male and testosterone to a female. As I alluded to early on, because of the differences between males and females, it's not surprising that there are many, many problems that one experiences. And these are sometimes life-threatening, complications. One of the studies that they actually looked at doing the affirmative surgeries, there was a death reported in this, put to the side, but a patient that actually died from a surgical complication. A very significant increase when you give estrogen to a male in having stroke, which can lead to neurologic impairment and even death. Increase cardiovascular risk, meaning the risk of heart disease. They have, we talk about, severe acne. This isn't somebody that's already very self-conscious about their body and having disfiguring acne. There's many questions that we don't yet have about the long-term consequences because we haven't studied it long enough. But the data that's out there clearly shows that there are medical side effects of this. And even those that are providing this care acknowledge that this does occur. They try to minimize this and present it in a way that probably isn't supported by the evidence itself. But in looking at the data, they always say, well, we can accept these risks because if we don't provide this affirmative care, they're going to commit suicide, so that this is a logical alternative to preventing suicide. But then we need to look at the data. Is that actually true? Is it true that you're going to, and again, this gets back to, what is actually going on and how one provides true and lasting healing. If you're accepting as a scientific premise something that's not true, if you understand something about the human body or the nature of the human person that's not true, it's not surprising, perhaps, that we see that rates of suicide and depression remain markedly elevated. And the way the studies have been done, we don't have the long-term data in children because they've not been treated long enough to be able to get the definitive data. The best data we have is in treated adults, and probably the best data comes from Sweden, where they have medical records of everybody in the country. So it's not a biased sample. You don't take an internet survey and just survey those that you want to recruit. recruit with an intent of getting a result that you want to have. And if you look long term, 10, 15 years after undergoing these affirmative approaches, the suicide risk remains markedly elevated, including completed suicides nearly 20-fold above the background population. That's striking. Now, this wasn't a controlled study, so one can't say what the intervention did, but you can say with complete confidence that it didn't fix the problem. Now, people will try to argue that the reason why there's an increased risk is because of social stress. Okay, that people just don't accept them for who they are. There's many, many areas of data that actually call that into question. If we look at areas of the world that are less or more accepting of this transgender ideology, we see very similar results. And so we need to actually acknowledge that this is not, contrary to what is being put forward, solving the problem. When we look at the data, and this is all-cause mortality, not just suicide, it's elevated in these individuals. And many times, okay, and this is another experience as well, the studies that have been done over a couple of years, when you look at what is emerging now of the number of people that are desisting, meaning that they have an experience, whether it's through a provider or a psychologist or through a pastor or just for a number of different reasons, come to this understanding and are able to back out of this this transgendered identity. That when we look at that, many times it's 8 to 10 years after or longer. So that there's a honeymoon phase where one seems to think that this is working, or there, as we heard, you keep doubling down and trying to convince yourself that it's working. So when you do a short-term study, we're often not going to get the results that tell us what's going on. So clearly, what we can see is that it's not working, and it's not just me saying this up here. If we look across the world right now, the European countries that have been doing this longer are coming to the same conclusions. So in Sweden and Finland, even the UK, France, they're starting to dial back in this affirmative approach and saying, at least wait a minute, there is very poor quality data. Maybe we need to prioritize psychological assistance to these individuals rather than the medicalization with hormones and surgery. And if we're going to be able to do this, it needs to be in a research setting, where we have safeguards in place and where we conduct the research as it needs to be done. Unfortunately, here in the United States, we've not gotten to that point right now, and they're at the stage of really escalating this, trying to dismiss this data as it's coming out. But I think the most powerful story are those individuals that are now coming forward and sharing their experience. For so many years, these individuals were shamed or intimidated into remaining silent. The same people that were encouraging them to proceed with this affirmation approach were completely ignoring them or demonizing them when they have this experience. But the numbers are growing. These people are to listen to their stories, and that's why I very much enjoyed being here with you at this conference. I think that is something that cannot be ignored. And the whole, moving away with ideology and trying to ignore the science is something that we need to be aware of. So I want to leave a little bit of time for questions if we do have time for that. But I want to just summarize what I've shared with you this morning. We are going to have a workshop this afternoon, and we can go into a little bit more detail on practical aspects, of how we deal with this and do more question and answers. But I think we do need to acknowledge that this is real and severe suffering that people experience that have this condition. And we need to have, compassion. We need to enter into that and really be willing, to engage in very uncomfortable conversations. We don't really know fully why an individual has this experience. We have much data that's emerging that we can sort out some of the influencing factors. That the current approach to treatments are based on ideological influences and very poor science. And in fact, it's such bad science that it's a threat to the entire scientific establishment to actually see science being conducted in the way it is. And we know many other examples beyond the gender questions. and that we need to explore alternative approaches. We need to be able to enter into this conversation. And so when you have these conversations, I do encourage you to feel at least a little bit emboldened that you have something to stand on beyond what you know from your faith, that there's science that's backing up the questions that are being asked, and that we need to be able to move forward with that. So what can we do? We do need to have compassion for the suffering, and really always recognize the dignity of every human being, regardless of their experience, that they are a child of God, and they need to be loved for who they are. I think there's much that can be done, even if there's differing opinions about what the best approach is, to really, there is some real discrimination that goes on that's unjust, and bullying and those types of things. We can work certainly to do that. And then, really the work toward evidence-based psychological support is something that I think with the existing data, we can certainly do that. I think another dimension of this relates to this intersection between faith and reason, that we can take what we know about human sexuality from the spiritual dimension and understanding of who the human person is. It's not just physical, but the physical, emotional, and spiritual nature of the human person. But we can't jettison truth about human biology, even if we strongly desire, to help an individual, because we're probably going to be not successful in that. I'd hope to have available for you a new book that's coming out. This is a short advertisement put together by a multidisciplinary group addressing the topic of sexual identity, both from the biological, the philosophical, and the theological dimension. It is available for pre-order on Amazon, but it's not going to be shipped until next month, and I just leave that with you as well. I also want to draw your attention to some of the many resources that are coming online, and that you can direct yourself to provide more information about many of the things that I've already shared with you. I have a couple of papers, again, if you want to delve into the medical scientific aspects of that, really that is all contained in what I shared with you this morning. Finally, I want to thank you for your attention. I want to thank you, all of you, for being here, for graciously inviting me here to speak. And again, if we do have a few minutes for questions, I'd like to open it up for you. But again, thank you so much for allowing me to speak.
So, for questions, if you have a question, why don't you raise your hand? I'll walk the mic over to you, and Dr. Hruz can answer. So.
And if we don't have time, for all of the questions, again, we'll have a workshop this afternoon. We'll have more time for that in a more specific way.
I've been wondering this for a long time, but where does the Hippocratic Oath fit in all this?
So the question about the Hippocratic Oath, and just so everyone knows, that many medical schools are no longer reciting the Hippocratic Oath at graduation.
Oh, wow.
You probably didn't know that. Or they've rewritten the Hippocratic Oath to update it, to the times. And so there's many things that they consider inconvenient in the Hippocratic Oath. So even the standards of the Hippocratic Oath are not being followed within the medical profession. The term do no harm, it's contained indirectly in the Hippocrates has stated that very clearly. The understanding of doing no harm is twisted in a number of different ways, and many of the arguments are made to do nothing is to harm the individual, and so that's how they justify this. So they say that even though we have no idea what we're doing and we don't know what's going on, we have to do something. I think the data that I showed you here clearly shows that this is not a neutral intervention, that we are sacrificing and causing irreparable damage to the integrity of the human body. There are situations in medicine where we accept that in a limited way with defined criteria. For example, in treating breast cancer, we'll remove breasts when they're diseased or you have a risk of that. But I think in other areas of medicine, to destroy perfectly normally formed and functioning sexual organs, to manipulate the body in a way that the body is not designed to experience, is indeed harming the body. So there's lots of ways that people are trying to interpret that. I think it relates to more ideology than it does to that principle. And I think that in other areas of medicine, faced with the same degree of uncertainty, it's not that we don't act, but we actually act with much caution. We often will reserve it to experimental interventions, and we'll certainly share with the individual that comes to the medical practice that we're doing something that we don't know what we're doing. That's not the way this is being presented, that it's not acknowledged all of these risks, the limited data, and what's going on. So, I think it's much to be concerned, and I would extend it beyond this conversation of gender. There's much that's going on in medicine that what many people believe, that where people are being intervening in a way that actually is a violation of that principle. But thank you for the question.
Can you share what the reparative approach would look like for individuals?
Yeah, so the question was to share in more detail about what is involved in the reparative approach. And again, just to review that is directed toward assisting the individual in realigning their gender identity with their biological sex. In the area of pediatrics, Ken Zucker in Canada really was the pioneer in that approach. And so I think where it focuses on is and again, this is often in the dynamics of these gender clinics, there's a move to steer away from engaging in investigation of prior psychological insults and things that might have contributed to the discordant gender identity. It's seen as a barrier to going on and getting the therapy, and they want to ignore that completely. But what it would involve is first understanding the psychological experiences that one had prior to the emergence of gender dysphoria, to be able to address those in a way that may allow healing. And as we heard, this morning, that there are many people that buy into lies about who they are as a child of God. They buy into lies about, not even recognizing that perhaps that abusive relationship with a family member or somebody within their school might have contributed, to the experience. So it's to help them identify these underlying difficulties. There is a part of it, and again, it's when we talk about it, it's a very broad envelope based upon the premise and the goal that can be manifested in many different ways. There are ways that people have tried that have not been successful. We think about the example historically, thinking that that's a socialization environment, providing them, with males with only male types of stereotypical male type of toys, and the same thing for the females, probably has less of a role with that. And I think that there needs to be an understanding that when we talk about gender stereotypes, there's a wide range of behaviors that don't necessarily fit into masculine or feminine, or don't need to be. There's many cultural influences, and I think people that are accepting the reparative approach are not trying to say how a child should act, but it's trying to understand of how one gets this identity issue of perceiving them of being a member of the opposite sex from the variety of ways. So the cultural experiences, the psychological traumas, and coping mechanisms that have been made over time. And then I would say that just as in the expectant approach, some of that it will involve, many times if one is involved in substance abuse, for example, or they have major depression, the ability to be able to have that restoration occur may be very challenging until they're able to overcome that. So that, trying to get, first things first. And so maybe this afternoon in the workshop we can go into more detail about specifics about where we can address that. But that's the general model of what can be done. And I think many of the questions about the best way to do that have yet to be explored. There is existing literature, and in fact, if you look at the W path, when they make this blanket statement that they call it conversion therapy, is proven to not work and it's harmful. If you actually look at the literature that they cite, there's actually examples of people that actually have had that experience of desistance within the literature that they use to condemn that as a viable approach. It's a very interesting dynamic that's going on. I think in the next version of the WPATH guidelines, they're going to take that out because they know that it's damaging to what they're trying to put forward. But much more I could say about it, but at least that background for you.
I have a niece who has believed the lie that if she doesn't affirm her daughter who wants to become a male, that she'll commit suicide. So she's believed that. What the information you've given here is just great. What can we do? Because the opposite is happening in the public schools, and your information is needed in the public schools because these young girls are making this, I mean, in multiplied places. And what
Right.
can the medical, at least the medical people who believe what you just said, what can we do
Yes.
to get the truth into the schools?
Yes. So the question related. It's very clear, that people are being told, and that suicide is the consequence if you don't affirm. It's challenging because there's been really a very successful effort to suppress the discussion of this scientific evidence, to dismiss it, to not allow it to be discussed, even on my own, university campus. I think the question really, I'm going to direct it toward all of you in the audience here, because I think all of you have a role to play in this, okay? I don't expect everybody, to walk away knowing all the ins and outs of the scientific literature, but truth is truth, and, you probably know the saying, right? What is necessary for evil to thrive? It's a lot of good people to sit back and do nothing. So I think that I recognize, that there's, the intimidation that occurs, and the uncomfortableness and the uncertainty about challenging these. One of the things, I'll say this maybe in the workshop a little bit in more detail, one of the ways to address this, if you're not going to try to, take a stack of papers and say, here, read this, you're wrong, is to ask questions. And I think all of you are capable of asking questions in a way that is non-threatening. To say, I heard somewhere that suicide rates remain markedly elevated after undergoing this, and you're telling me that this is going to prevent suicide. But why is it then that there's a 20-fold increase in completed suicides after you do this? I'm trying to understand this, and I can tell you what the responses are going to be, and we can go into more detail about that to be able to have the next line of questioning. But I think that's many people, even within my colleagues, okay, understand there's a problem, but they're unwilling to engage because of the dynamics of what's going on. So it is a challenge we have, but truth will prevail. We know that.
Dr. Hruz, I just want to say thank you so much for your presentation.
You're very welcome.
It's a very powerful.
Thank you.
Very powerful. Thank you, sir.